right, hi everyone. Thank you for joining us today for the case of the week. My name is Kara Borzecki and I'm the Education and Credentialing Coordinator. I'd like to introduce our speaker, Dr. William Liang. He's focused on his practice in implant dentistry for nearly 30 years. His clinic is located in Surrey, British Columbia near Vancouver. He's also a diplomate of the ABOI and an honorary fellow of the AAID. He's currently the chair of the AAID Maxi Courses and directs the AAID Vancouver Maxi Course. 2020 marks the 10th year of the Vancouver Maxi Course, and here he is.
Great. Well, good afternoon, Karina and Carol. Thank you very much for having me present to you. Good afternoon, everybody, ladies and gentlemen. Let me just start my screen share here, and let's hope that this will all go well for us here. And I hope you're seeing my screen here. Yes, so indeed, it is the 10th year of the Vancouver Maxi Course. We actually last year thought about doing something spectacular and memorable. And certainly this is not something that this year has not been, well, it has been memorable, let's put it this way. I guess it has been spectacular as well. But certainly not in the way that we had anticipated. But nonetheless, it's great to be sharing Vancouver virtually with you. Vancouver is really as pretty as it is in this photo. I wanted to share this case with you today because I think it highlights what we do at the Maxi Course throughout North America and worldwide. And it is really to develop competency and to develop proficiency as well. And in this case, I want to talk about a practical solution for restoring the anterior segment of this young lady. She is a 37-year-old lady. She's very, very active, and she swims regularly. So, and she's a professional engineer. She is concerned about her front teeth. So she was referred to our practice with the chief complaint that she has some aching teeth and in the upper right segment. She presents with very loose central incisors and the lateral incisor. And she said that she's afraid of talking and afraid of even using her teeth, and being in public is a bit of a stress for her because the teeth are very, very loose. So we looked a little bit further. You know, she does have a very unusual bite. And at first clinical glance, she's told me that she's been orthodontically treated as a child, but it didn't go well because childhood environment changed on her, and she admittedly was non-compliant. Okay, we have so many young people that were non-compliant during the teenage years. And so the clinical presentation of this case was that she presents with an anterior open bite with tooth numbers 7, 8, 9 with class 2 mobility. For my Canadian friends, I'm speaking American, being bilingual today. So we splinted, the teeth were splinted together at the time of presentation. And the overall hygiene is very good and surprisingly good. And her dental IQ is very good. And this is a time when you see an occlusion like this, you know, the first thing that comes into my mind after, you know, almost 40 years of practice is, okay, let's just assess the emotional stability of this person and what is the patient expecting, because I think expectation management should come first in mind for you. And then we look at periodontally, clinically, it actually she's doesn't have much gingivitis at all, and there is evidence of recession around tooth number 16, 29, and 30, and the evidence of the previous 3 gingival grafts in quad 4 or sectin 4 and 6, which we'll show later on in the other photos. And so she's generally periodontally healthy, and she's occlusion is, there's a little typo in there, sorry, I forgot to change it. It's skeletal class 3 and actually class 3 dental malocclusion, and it almost looked like she's bimaxillary protrusion from the dental cast, but facial profile wise, she's okay because she's actually missing tooth number 6 and 12. And then there's a buccal crossbite around 27. And so there's no reported or evidence of temporomandibular dysfunction or TMJ problems. And surprisingly, again, when you look at the occlusion, this dismounting is maybe a little bit open, and but you look at the occlusion, she's really just functioning on the molars. And there's very little occlusal wear for somebody that's, I think, 37 or 38 years old. In terms of her smile, she has a slightly high lip line. You can see that the gingiva here is mildly showing when she has a small, light smile. And but the midline is reasonable. There is a diastemer. There's a little line, the yellow line I put on there is blocking the diastemer. And it's actually temporarily closed by the composite material. And the cuspids here are slightly longer, giving her, if you look at just the dentition itself, there's a little bit of a potential reversal of the curve there. And there is an adequate band of tissue, keratized tissue around all the anterior teeth. And if we look further, we can see that the gingival margin here is a little bit higher, and the number 7 almost appear like it's a little bit intruded, and the tooth is significantly shorter. We have also a slightly uneven occlusal line in the lower. And this is where you can see that, for those of you who are familiar with orthodontics, the A and B angle is quite acute here. So that's what we've got. And looking at the radiograph, now this is reminding you that this is a case that we treated in the beginning of 2011. And in 2008, that's when we started to have CBCTs available in Canada. And so we did a combination of course, we made use of the radiograph that was provided by the referring dentist. We see a periapical radiolucency here. And then we went straight on using CBCT as one of our main analytical tool. You get a nice little panoramic image here, and we're going to look a little bit further. And you can see that this one, this image is of the number 7, and this is the cut from the CBCT. And we have a very bulbous root here, as well as some labial gingival recession, very, very short roots. There's a concavity at the apical region of the bone. And from the crest to the constriction, there's about 8 millimeters of space there. So once the tooth is removed, I would say that I can give that a division A minus H kind of division classification. And then looking at tooth number 8, oh, sorry, we went too far. Looking at tooth number 8, this is, again, the cross-section of tooth number 8, and you see that there's hardly any root there, and a larger concavity at the apical area and constriction here. There's only, again, maybe about 9 to 10 millimeters from here to the base of the concavity. So definitely this would pose a potential problem for us. At the constriction, we've got about 3.5 millimeters of space here. And moving on to look at, oops, sorry, again, gotta go back. Moving on to look at tooth number 9. So this is great, it's good to see at least, the one side that is reasonable, but then there's no root left. So this is obviously a result of many years of orthodontics and incompliance, and that's kind of explains why her teeth are so loose and she can't use it. We did have an orthodontic consult as well. The patient's resolve basically is that she doesn't want to have any more orthodontic work done. She's prepared to do whatever is necessary. She's feeling completely comfortable with the rest of her mouth. and she takes good care of her teeth for what occlusion she has, but she does not want to have or entertain the notion of doing any ortho or root canal treatment. So she knows that these 3 teeth are doomed, and she's been told by her periodontist that they're pretty much doomed. And my idea of having the orthodontic consult was largely to just try to improve her occlusion and prevent any further potential damage because she's only 37 years old. But so we did have the orthodontic consult, and actually I spent a fair bit of time with my orthodontist colleague going over this case, but she rejected the orthodontic treatment in the end, and she said, I'm just going to live with this. So at this juncture, it's like, we're traveling down the highway, and all of a sudden you've got to take a road. You got to go off the highway or stay on that course. And so we're going to take the offshoot, and the clinical reality is that at this point we have to approach our treatment with the conformative approach. So we can no longer have in our mind that we're going to reconstruct. And this is one of the clinical realities that we have to face as dentists to serve the needs of our patients. In an ideal world, if everything lines up exactly the way you want it, that you can probably go down the road of reconstruction. So in the conformative approach, I think the main thing for us to really understand here is, we have to maintain the current aesthetics, possibly improving it a little bit. The patient has indicated that she's happy with the way things are in terms of the appearance, as long as she can function with it. So that is the end in mind. We begin with the end in mind with everything that we do. But the thing is, we have to assess the risk. What are the risks in the near, medium, and long term with what we do? And what are we compromising when we're looking at this in terms of the aesthetics and the prognosis? So having to keep all the teeth, we have certainly these options available to us. So we've got the choice of doing nothing, or removal of partial denture, which is not part of this conversation. So I've so we're going to just gloss over that. We're going to potentially remove just number 7 and replace it with a single implant, but then that leaves the 8 and 9 unattended. Or we split the 8 and 9 with fixed partial denture, and again, then you end up having 2 loose units here. Or you can actually try to split all 3 of them. That's also an option. But if we're to go with the fixed partial denture, like a fixed bridge, it will have minimally have to be 4 units, going from number 5 to 8 and 9. And again, this is now like a torque wrench, because now 8 and 9 are loose. And if number 5 is not loose, it will be loose after some time of function. And then the whole unit will probably have a very, very poor prognosis. And then we look at option number 5, remove all 3 compromised teeth, and then we restore the area. But then now you have to double abut. And double abutting means that now you have number 4 and 5 as abutment, 10 and 11 as abutment, and you have a 7-unit bridge. Now this actually is a viable option. It's what we used to do prior to the 1980s. And this is what was available to us. And if we control the occlusion properly and with the right case, I actually have many cases like these that are patients with long span bridges that are in function quite well. So that's but that's not exactly what she wants. I mean, this lady has virgin teeth in 4, 5, 10, and 11. So option number 6 would be to remove all 3 teeth and then replace 2 root forms, one in position 7 and one in position 9. Or we remove all 3 of them and place implants in 7, 8, and 9. So at this point, I'm going to launch a little survey, a little poll for those of you in the audience. Let's see if I can do this right. So this is a poll that is, Karina, can you tell me if it's been launched? Because I just pressed the button. So this poll is, oh, it said it's closed. Okay, I'm going to launch this poll here. So I think I think only me can, only I can see this. But I'm going to leave this for a little bit. We're not going to discuss it, the results, until later on. And I'm going to take you along while this poll is going along. And let's look at some of the general consideration. Basically, you should be aware that the more extensive the treatment plan is, it carries out a higher risk, and implant-supported restorations tend to have limitations. And dialing back to our understanding of dental implants 10 years ago, there are certain things that we need to consider when we place implants side by side between in a tight space. And then the expected results may or may not be, depending on what the clinicians, I'm just writing down the results here as I'm just, so the expected results may very well depend on what the clinician's proficiency or level of proficiency is. And so this is a little Venn diagram that I've created that we use in our Maxi course all the time. Basically, when you evaluate a case, you have to look at the patient's aesthetic desire and what does the patient really want. Most patients really want something that looks good, feel good, and lasts a long time. And then as a clinician, you have to sort of decide, when you're taking on a case, what is your experience, what is your treatment philosophy, and what is your competency and your proficiency level? And when we talk about competency development, it is basically a skill set that you develop through a organized approach to systematically look at your clinical situations. And proficiency is something that you develop over a long period of time with mentorship and over a lifetime. And so here, the little area in green will kind of show you what the clinical reality is. When you're able to bring all those things together, you'll be able to reach a clinical reality. And through, I guess, a lifetime of learning and continual improvement with competency and proficiency, and through understanding of your patients, you're able to then increase that green area, increase your clinical reality. So some of what I say here, or whatever cases that you take on, and after you do the rationale, you may not, it may be cases that you can do, and it may be something that you don't want to be doing. So, currently, well, actually, I think I'm going to just share the results later on, and we'll just continue on. So we're looking at this, but after talking to the patient, for whatever reason, she is very, very adamant that she really wants to, for every tooth that she loses, she wants to replace it with a dental implant. So she really wants to have 3 implants in her mouth to replace the 3 teeth that are going to be removed. And so it, basically brings us to these 4 questions. So if we're going to do the 3 implants, first of all, is it possible? What is our experience? What is, I would have to ask myself, what is my clinical experience? And what is the profession's dental experience with these type of cases? And what do we know that we can work with? And what are the things that we need to avoid? And what are the risks and benefits? So expanding along that, but there are many issues that we need to consider, but I just kind of wanted to discuss with you these 7 questions. And let's answer these 7 questions and go through the action of how we come to a conclusion, how we derive our treatment plan. So this is more an exercise of showing you what we're thinking about back in 2011. So looking at the literature back then, there was a lot of conversation at that time in the late 2000s about immediate implant placement, immediate extraction and implant placement, flap or not flap. And the conversation was quite in favor of immediate implant placement with caution. And here, this case, this paper in 2010 says the careful case selection was determined to be the most important factor to avoid treatment failures and aesthetic complications when deciding between immediate or delayed implant placement. So there is, and then it further suggests that evidence available indicates that it is a successful procedure and may benefit the patient. And so there is evidence that favors immediate implant placement. Another study supports that the flapless immediate implant surgery produces a significant reduction in vestibular biologic width and minor reduction in buccal bone plate resorption. So the conversations at that time and the literature seems to support that we should be removing or placing implant and immediately after extraction and with careful planning to preserve residual bone and the soft tissue architecture. So we draw that conclusion. The next question is, well, you know, do we place 2 or 3 implants? Well, here's a study in 2011 that shows that they concluded that implants should not be placed closer than 1.8 millimeters. There is a significant difference between that distance. If you place them too close, you're going to lose bone. And at the same time, Carl Misch has already published and suggested that perhaps you should have the distance between implant and root surfaces should be about 2 millimeters, and implants should be 3 millimeters in order to avoid crestal bone loss. So at the same time, this is kind of at the turn of the century, Dennis Darno and his group did some research, and they suggested, and in a way they're answering my 2 questions. You know, do we place 2 or 3 implants, and what kind of implants do we use? And they're saying, well, you know, if you use the platform switched implant, you may be able to get the implants closer than the 2 to 3 millimeters and be able to have the bone survive. And in fact, they've seen that the platform switched implants have bone growth of about up to 0.5 millimeter over the implants. One of the most groundbreaking ones in my mind in terms of study is Dietmar Wang's study back in 2008, where he compared the differences between external and going back again. He compared the differences between the external hex implants when placed subcrestally on the effects of bone, which died back there, and the platform switched implants when placed subcrestally, and what the bone level does there. So he highlighted that the importance of implant design and the type of connection and the use of platform switching in the bone maintenance. And it tells you that basically, you know, if you're going to place the implant subcrestally, you should use a platform switched implant. So another study here says that in the aesthetic area, it may be necessary to place the implant platform more apically to produce the desired gingival masking and emergence profile. Now, if you think back in the early 80s, a lot of us were placing implant quite far subcrestally because we were trying to avoid this problem, trying to avoid the gingival showing of the problem. And we actually created a peri-implant problem by creating a very deep gingival pocket. But it sounds like at that time, in 2011, we have enough evidence that that a platform switch implant can actually preserve bone level. So here's in my own hands, these are 3- and 5-year post-restorative results. And you can see here that the bone level actually is maintained quite well and growing right over by actually more than 0.5 millimeter. It goes over the implant. So it tells me something. The conclusion I drew from that is that it is possible to place implant closer together if they are platform switched. The implant connection plays an important role in the maintenance of the bone level. And then also the depth of the implant placement subcrustally may influence the bone maintenance only if you use the right type of implants, okay, the right type of design. And so if it's going to be subcrustally placed, we should use the right type of implant. So having answered these three questions, then the next one, again, there were a lot of conversations around whether you should graft or not graft, whether you should use xenograft, allograft, at that time, the jury was really still quite in its infancy of trying to decide what to do. But there were studies that shows interesting results. In this study, it shows that when they use BIOS graft into the human socket, the bone that was formed is actually lower than the less bone than the ungrafted site. So there is volume preservation by using BIOS to preserve the socket, but the new bone formation is retarded and inefficient compared to the naturally healed socket. So it means that, you know, there's a give and take. You're either going to preserve the volume of the bone, and then you give up the bone formation because it actually takes longer. And later on, we have the term bioburden, which we know actually because when you put in some material, it takes time for the material to be resorbed and then turn over to new bone. So it is beneficial to graft the socket to preserve the bone volume, but you have to be aware that grafting in the extraction socket does delay bone formation. So do you place an immediate provision or not? You know, now if we're going to place an implant in there. So in here, a study in 2008 shows that there's no difference between the immediate placement and immediate loading group when you look at the radiographic evidence of the bone growth. So what they're saying is that whether you place the implant immediately after extraction and you put it into load or not, the bone growth is the same. And so there's evidence that, well, perhaps, you know, in the right case selection, if the load is managed again, you know, what I don't show here is also a lot of discussions about micro loads compared to macro loads and how it affects the bone maintenance after immediate implant placement. But it certainly works. But the alarming thing here is that most of these implants after immediate implant placement have 96% survival rate, but there is a 21% chance of aesthetic failure. So you have to be very aware that if you're going to do immediate provisionalization, you have an aesthetic risk of 20%, 1 in 5. So to me, I think, you know, wow, you know, that's something that I need to think seriously about. In this case, with this young lady, perhaps not such a big deal because she's not in function. She doesn't have occlusion in the anterior. But having said that, you know, my preference is probably knowing that there's a potential 20% of aesthetic failure. That being one of my main goals, I would be very cautious against that. And then the last question is, you know, what kind of final restoration do we want? We're dealing with tight space. The patient wants 3 implants in there. So I'm concerned that there's potential show through of the implants. I will have to place these implants into a smaller arc, more palatally, so that we can avoid any untoward gingival effects or anterior or buccal bone loss. And in doing that, when I place it into a smaller circle, these implants are actually going to be getting closer and closer to each other. And So my desired clinical outcome here is to have basically something that has similar strength and durability compared to the titanium. And then the abutment should be aesthetic with no tissue shine through. We're concerned about the tissue shining through, and it has to be biocompatible with the gingiva. And that leads us to considering zirconia as an abutment. And at that time, the studies were showing very promising results with zirconia. Here, this study shows that the 5-year rates of ceramic and metal structures appear to be fairly similar. But then, of course, just to be careful, they always say more follow-up times. In fact, the Europeans have used the system ankylose quite a bit at that time, and they did a lot of studies on zirconia, and they found that the zirconia to be a very favorable material to be used in the anterior, especially in the anterior region. So here is another favorable study for the cause for this zirconia, and that's 2010. They said that they have good function up to 4 years without mechanical problems. The peri-implant soft tissue responses for zirconia has been very favorable, and the zirconia appears to have a lower tendency for surface-bound bacterial plaque in the early stages. So, and another one here in 2011 shows no difference in the light reflection between titanium and zirconia when the tissue is 2 millimeters thick. So if you have a tissue biotype that is 2 millimeters thick, it really doesn't matter whether you use zirconia or titanium. It is during the transition from the gingival crest down to the 2 millimeter. If you have a very, very thin gingiva at the crest, then there will be a light casted. So that's when you see a little grayness showing through sometimes. So, what can we conclude from this? Well, based on the literature at that time, titanium abutment and PFM systems have certain risks. The visible margin of the gingiva may recede over time, and then when the recession starts or the tissue starts to thin, you see a little graying of the restoration. And then the PFMs tend to become whiter as the porcelain age or becomes more opaque. And then it increases the discrepancy between the titanium and the PFM opaqueness. So aesthetically, in the long term, this titanium and PFM sort of combination does prevent some drawbacks that we know of. And the zirconia, of course, does not have that grayness, and then you would probably choose to use a zirconia abutment with a zirconia crown. And it does have some additional advantages that was noted at that time, that it may be a little bit more plaque resistant. So, and at that time, I actually was playing around with titanium, with the zirconia abutment quite a bit. And here's a case where we used an ankylose implant with a zirconia abutment. And that's on tooth number 10. And I think the results were pretty good. Do I need to have a zirconia abutment in this case? Probably not, because as I said, there was quite, if you have adequate tissue, you're fine. And there is quite a large band of attached gingiva here. But if you look really carefully, even with the zirconia abutment in there, you can still see a slight grayness coming from here compared to the other side. But overall, the zirconia abutment did yield us a pretty good result. And here's another one for tooth number 7. Yeah. So tooth number 7, and another case, and again, it yielded pretty good result with the zirconia combination. Okay, so having answered all those questions, this is the note to self. I want to do immediate extraction. I want it to be flapless. I'm going to use bone manipulation to modify the bone division, and For that, I thank my mentor, Dr. Hill Tatum, who has taught me bone manipulation and taught me many other things along with that, and has been a huge influence in my dental implant career. So I know that using a platform switch implant may be the thing to do because I have to place these implants closer together in the smallest circle in the arch, and that I would be placing the implants a little bit more apically, and whether I graft or not, that the jury is out. And often what we do is we take the bone from the osteotomy and then we graft it back into the site anyway. And then I will try to maintain greater than 2 millimeter interproximal distance between the implant. And then if it is possible, I will provisionalize, but my goal here is for final aesthetics to be at optimal. So I talk to my patient to say, well, you know, maybe we should use a removable partial denture as a provisional. And then you want to choose your final abutment very, very carefully. We are going to, because the patient is bimaxillary protrusive, we are going to be placing these implants at a pretty high angle. And in those days, we did not have the ability to have angulated screw channels that we do have today. So those screws are going to be have to be exiting labially. And at the same time, these abutments are, you know, if you're using standardized abutments at that time, they go up to a maximum of, I think, 20 degrees. So you have to be very careful that you have enough angulation. Or at that time, I think that was the time when we started to have custom milled abutment. And so you have to make sure that the implants that you choose has the support where you can get the angulated milled abutment to be able to correct these severe angles. And the important thing is to really manage a patient's expectations and obtain informed consent. That is the number one reason why dentists doing implants get into trouble right now all over the world, is because the patients were not informed that what the risks are. And so you know, both parties, you and the patient, have to go into this relationship with eyes wide open. So after you get the informed consent, then we basically go to do it. And this is the proficiency part of the exercise. We did a traumatic extraction with peritome or a Benex extractor. I can't remember. I think I used a Benex extractor. I should have looked back in the chart. It's one of my favorite tools. We removed 7, 8, and 9, and we used immediate implant placement techniques and using the osteotome to manipulate the ridge at the apex of 7 and 8, and we basically just expanded this site and then grafted into the extraction socket. In this case, we used the allograft. We use autograft because we kept the bone from the osteotomy, and then we used a platform switched implant, which is ankylose. It has a very nice Morse taper that I enjoyed at that time. There are many other implants now that are similar. So, and we place the implants subcrestally. So we did consider the immediate provisionalization, but I had my way, so I used a removable partial denture for the patient, and then we did with the zirconia final abutment and the crown. So let's look at some photos. I'm sure you're bored of all the papers and stuff, but that is an important part of the thought process. And once you actually go through the systematic part of developing your case, the execution part of it should be very, very simple. I mean, it's you know, it's just the doing part. You just develop your proficiency at delivering the care. So here's the case At the time when we placed the implants, we used ankylose 11 millimeter. So A means 3.5 millimeter in diameter. These are 3.5 millimeter implants. And we placed an 11 millimeter here, 11 millimeter, and then a 9.5 millimeter. Now, and then these are sulcus formers that are of 3 millimeters and 4.5 millimeter height. So, you know, you may ask, why was the implant placed further subcrestally in position 7, number 7? Well, remember, in number 7, the bone is actually, the crestal bone is actually higher up. There is a case to be made to, you may want to say, well, why not just extract the tooth, graft the area, and then go back there and place the implant? Maybe this bone at the buccal crest will come back a little bit. Maybe, and maybe not. But if you do that, you know, there are some certain drawbacks. For example, you know, it would be 2 surgeries for the patient, a little bit longer. You're no longer preserving the crest of the bone. If the labial plate is already thin as it is, there's also a possibility that even after you graft the site with a biologic to preserve the width, you will still have some shrinkage. Then you'll have to do bone expansion, and you may not even get the height back. So, you know, it's a big, long discussion that we can certainly have if we have time later on. And then what degree of confidence would you have to maintaining the bone height between 8 and 9? Well, it so happens that with the midline is actually one of the best areas to try to maintain the bone in between implants. It is the one area where I have very little hesitation to place 2 implants side by side. And this is probably the one area in the mouth. So, well, let's look at what we got. So here's the result, and this is the trajectory. So if you look at the, let me just use a different color. If you look at the trajectory of the implant, it is really sticking out, and we place it a little bit more palatally as well. So you've got these implants that have pretty severe angles, and you know, without seeing the entire treatment plan and knowing what the entire treatment plan is going to look like, sometimes somebody looking at the restorations like these, or before it's restored, looking at implants like these, you know, they might make a snap judgment and say, "Oh my God, you know, this is crazy." So this is our partial denture, and the partial removal. It's just basically what, you know, the orthodontic flipper acrylic partial, and that's kept away from contacting the implants. And then at 4 months, we take impressions, and then we start the restoration process. It is essential, especially for these implants, to be using a jig. And if you don't, these are non-indexed implants at that time. Ankylose did come up with index ones afterwards, but these non-indexed implants basically can rotate in every direction. So, and they're tiny, tiny little abutments. So you do need to have the jig. And in fact, anytime when you see crowns in the anterior area, whether they're indexed or not, the abutments are indexed or not, you should try to use a jig and get your lab to make you a proper jig so that you don't, it's not so easy to drop it into the patient's throat. And this is the view of this flimsy, tiny little abutment after it's inserted. Now, what is wrong with this right now is that I didn't see this case at this time because it was too bulbous. And you can see here that when we look at the photos, there is too much bulk here. If you leave that much bulk, the gingival tissue is not going to be happy around here. And with this kind of a pressure, it is going to cause gingival recession. And then also interproximally, this is over contoured. We try to send radiographs at that time. We try to send radiographs and soft tissue. Of course, there's a soft tissue model in the impression for the lab, but that just didn't happen there. So what we did was we sacrificed the crown. And we adjusted it with a fine diamond to the contour that I want, and then send it back to the lab so that they have a good reference, and then see compared to this here. So we have a good reference, and then the crowns were remade, and then they were reseated. And even at that, at the time when we seat the crowns, you can see these are very narrow now. They've remade them to be very, very narrow. These are 2.5 millimeters at the exit from the division A, sorry, from ankylose A implant, which is 3.5 millimeters in diameter, and the neck is 2.5 millimeters. And so there is pressure when you put the apply the pressure. If this pressure goes away after about 5 minutes, then it's perfect. You can just cement the crown. But if it doesn't go away after 5 minutes, then we pretty much know that we have to anesthetize the patient and make a little bit of a cut interproximally to free up the tissue so that the pressure can be released before you cement the crown. Because if you have continuous pressure on these crowns at the time when you seat them, you're going to put pressure on there over the next few weeks. You're going to see immediate bone loss around those implants, because the bone is partially supplied by the blood supply that is overlying the tissue. So this is just immediately after the implants are cemented, and they are, there's a little bit of bleeding in the area. Now, you notice that this is 2011. We did not have the ability to do screw retained implants, crowns that are that have such severe angles. So we have to be very, very careful with excess cement. So what did we achieve? Well, the clinical outcome that we achieved was that we met the patient's expectation of causing the least trauma, quickest result. Basically, the teeth are removed and implants are placed in one appointment, and then the next morning, the removable partial denture is given to the patient. We have achieved, I think we did achieve aesthetic improvement. She's got a nice smile line now. The balance is quite nice. And then more importantly, we achieved one implant per tooth that the patient wants. So now I'm going to maybe relaunch the poll. I'm not sure if I can do that again. Okay, so the poll is relaunched. Based on what you've heard with my presentation so far, would you place one implant, oh no, sorry, two implants? Those of you, I don't know who's online, but some of you from our Maxi course, I always joke, did I tell you I hate cantilevers? So no, not one implant. So it's either 2 or 3 implants in this case. So let's look at, let's see, I don't know what your answers are yet, because you might change your mind after you look at the long-term results, because the case is not a case until we look further, right? So here's in 2004, oh, sorry, 2014. This is a panoramic radiograph showing that the bone level is largely unchanged in this case here. And then in 2017, again, you can see that the bone level is largely unchanged. And actually, I think if you look carefully at it compared to the 2014, it actually looks better. It actually looked a little bit better. And that's not unusual for us to see that. And then here's a comparison. Here's in 2011, at the time when the implants are placed. Okay, we do expect a little bit of a dieback at the time. By the time we restore it in December, this is the bone level here. And then in 2014, we've got bone level like that. And then here is December 2019, and the bone level is again, actually, I think comparing that to 2014, it is definitely better looking. So far, so good. I was going to call the patient during this COVID pandemic. We can't call her in to get a photo. I wanted to see what her photo, what the teeth looks like and what her photo will tell me. And I was so desperate. I almost called her to give me a selfie, but no, it didn't. We didn't do that. But anyway, I hope this sort of will highlight to you the thought process. And if the thing is, the clinical situation is a very complex situation. It's not just complicated. The complexity of it lies in the fact that there are a lot of unknowns. We don't know. There are a lot of host factors and environmental factors that we don't know. But if we continue to hone our competency and we base our decisions based on what is known literature and then develop our proficiency to meet those criteria, then I think we have a fighting chance. And so in this case, we've got a 9-year-old case. I think it worked out okay. So I hope you enjoyed that. And if there's any questions, oh yes, so the poll results. Earlier, when I first started the presentation, 83% of you said that you would place 2 implants. What happened to my, I think, yeah, sorry. So I gotta look for the poll results now. So the final poll results is that 71 of you will place 2 implants, and 29% of you now will place 3 implants. So fully, actually that's something that I expected, because based on what I said, it really is, there's nothing wrong if you decide to do 2 implants. There's nothing wrong with that. And in fact, it remains my choice when I deal with these type of situations. Because if you have to place 3 implants, it becomes a far more, remember that when I said at the outset earlier, the more you do, the more complicated you're making it. And it taxes on your level of proficiency and your skill set. So it is definitely a safer thing to do. I see some of you, I have convinced you that there is a possibility of that. And of course, that's, we also have to kind of rely on what is current literature as well. What I would do today, I would do a lot of things differently than this. Do we have any questions?
Hi, Dr. Liang. I do have one question on Facebook.
Sure.
This is from excuse me if I mispronounce your name, Herberth Parada. They said, really complex case and an excellent result. Congratulations. What will be your advice with the new options today?
Okay, yeah. Well, that should be another, that could be another half a day. Okay, so that's a great question. Thank you very much. And I'm glad you're observing this with the perspective that this is a thought process that occurred back in the 2011. And what I would use today, at the risk of glossing over some items, some of the more obvious things for me would be that I will not use a zirconia abutment. I would use a titanium abutment, a tie base with a zirconia block, because I found that in some cases, the zirconia, we've actually had some zirconia abutments break, especially when you have the Morse taper connection that is connected into the titanium implant, the stress on those over a period of time is sometimes too much, and it depends on the function of the patient. So I would definitely stay away from using zirconia abutment connections. Whether I graft or not, I think there's enough studies from, especially from the groups in Loma Linda, if you reference Dr. Jaime Lazada. I think that there is, we granted that we understand that there's the new term now of bioburden. Anything that you graft into a socket, any graft material that you place, whether it's even gingival graft with alloderm or particulate material that you're grafting in, the body has to resorb it. It has to take it away. So there's energy that is required. So there is a delay in time. The bone quality that you will get will be somewhat delayed. However, the trade-off is you're gaining volume. So I would graft. There were people used to reference, and I talked to Dennis Tarnow when he first said, well, you know, he came out with some studies, some finding that he said, well, I don't graft anymore. And this was about 10 years back. And he says, well, I don't graft anymore because we have found in our studies that we don't need to graft and the bone fills in. And then if you ask Dennis now, his longer term experience is that you should graft. So we do graft, and I always graft around the implants to preserve the bone. In terms of, you know, I would definitely try to use a screw retained restoration with angulated screws if possible. It is now possible to get pretty high angulation support from manufacturers. Then you eliminate the need to deal with the potential complications of cement extruding around the crown. Let's see. Other than that, I think probably, you know, a lot of the principles are about the same. You know, you may want to improve the gingival aesthetics by inserting a connective tissue graft around tooth number 7 at the time of implant placement as well. So, yeah, in a nutshell, maybe those are the you know, there may be other things to consider.
Okay, and we have 2 more comments. We have Dr. Ali Mostafavi that said, very interesting and comprehensive presentation. Thank you very much.
Thank you, Ali. Yeah.
And then the next question was, how do you adjust the occlusion, and do you recommend Nightguard? Thank you.
Okay, in this case, there's no need to adjust the occlusion because as long as the interproximal spaces are adjusted appropriately, that it doesn't put an inordinate amount of pressure on the adjacent teeth. Because this patient, remember, she has anterior open bite. We are restoring her to a conformative approach. So we are leaving her in a bimaxillary protrusive position, and so she really doesn't have function. I did bring the incisors in to make it less flaring to improve the aesthetics, but she's not really in function when she bites down. So a night guard is not necessary in this case. In most other cases, you would have to really consider what is the etiology. This patient doesn't really have any parafunction. I think she lost her 3 teeth basically from the excessive movement due to the orthodontics and the lack of compliance on her part. So she doesn't have any parafunctional habits. But you're right, you know, in most cases, we have to look at the etiology. And the first questions that I have with patients when in consult is, how do you think you broke the tooth? You know, why did you lose this tooth in the first place? And we try to get to the source of it.
So that is all the questions. And I do believe you had your email up for anyone who can think of any at a later point. But we thank you again, Dr. Liang, for sharing your case with us. We'll be back next week with Dr. Emily Mustafavi. And stay safe, everyone, and we'll see you next week.
Well, thank you very much for the opportunity to share with you, and hopefully we'll see each other in November at the convention or the national meeting that we have. And if you see me in the hallway, please come and say hello, because I have no idea who is watching this. Thank you very much.